so slow. Okay. The next thing that we're going to talk about is pharmacokinetics. And basically this is a study of how medications enter the body, reach their site of action, metabolize, and exit the body. So basically this is what the body does to a drug. So once you take it, this is what happens. And it's divided into 4 stages. Okay? So pharmacokinetics, what the body does to the drug. It consists of 4 stages. And I'm going to mention these now, but we're going to break these down and talk about each stage. But absorption, distribution, metabolism, and excretion. Those are your 4 processes that happen. Okay. Here's your nice little picture. Shows the absorption, the distribution, the metabolism, and then finally the excretion, which means what? Leaving the body. Okay. All right, give me some ways that we actually give drugs, some routes of administration. Oral. So if we give an oral drug, it goes to the GI tract, correct? Okay. IV, okay. Topical, intramuscular, subcutaneous, in the fatty part, in the subcu tissue or the fatty part, topical, sublingual. What is sublingual? Under the tongue. What is buccal? Against the cheek. Okay. Yep, between the cheek and gum. And those absorb a lot faster, and there's some drugs that we have to give that way because of how they react in the body. We'll talk about those next. Alright, so the first part is absorption. And absorption refers to getting the medication into the bloodstream from the site of administration. So getting it from wherever you gave it into the bloodstream. Okay? So from the site of administration to the bloodstream. That's what absorption is. So it's drastically affected by route of administration. Why?
Because the route that is taken depends on what they're going to do.
Right. So give me an example of something that's probably going to take a little while to absorb. A pill that you swallow. Because remember we said it takes the long scenic route? Okay. Give me something that would be fast to absorb. IV. Because to get absorbed is get into the bloodstream. What happens when you give something IV? You're putting it directly into the bloodstream. So your absorption for IV medications is immediate because that's where you're putting it, is in the bloodstream. Okay? What about IM injections? Do you think they react pretty fast? Not as fast as they do on TV when they give them the EpiPen. It doesn't work quite that fast. But they do work pretty fast because the blood supply to your muscle is very good, or it should be very good. Okay? Subcutaneous, not quite as fast as IM, but it's faster than oral. Okay? And then sublingual and buccal are going to be very close to subcu. They're going to work pretty fast. Okay? Number 2 is the ability of the medication to dissolve. Does that make sense? Okay. How many of y'all take goody powders or stand backs? Okay, I'm not a big proponent of goody powders or stand backs, but why do you take it? Because it works faster. Because the body doesn't have to break that tablet down. It's already in powder form. Okay? Goody powder? It's like a pill that's been crushed up, so it's just powder. Yeah. There's a lot of little white stuff, I know. Yeah. It's like a crushed up medicine. Yeah, it's like a crushed up pain medicine. But that's why people take it, it's because it works faster. So the easier that medication is to dissolve, the quicker it's going to absorb. Right? Everybody good with that one? Alright, blood flow to the area of absorption. In order to get medication into the bloodstream, you have to have a blood supply. So, if there's a limited blood supply or a decreased blood supply, then it's not going to absorb at all or as quick. Okay? So if you're given an IM injection, but there's not good blood supply to that muscle, is your medication going to absorb quickly? No. Typically, IMs absorb really fast because of the vascular nature of the muscle. But if there's decreased blood supply to that muscle for some reason, then your absorption is going to be affected by that.
Like if you're giving an IM to a person who has a stroke and you're giving it to the affected side?
Even with a stroke, the blood supply is not always what's affected. It's the brain, and that affects the motor function of that side. But let's say you had somebody that had peripheral vascular disease, and so they don't have as much blood supply to the lower extremities, and you were going to give an injection in the leg, then you could have some problems with blood supply to that area. Okay? Body surface area. Okay, this one's always hard for me to explain, and I apologize, but this is the only way that I can come up with explaining it. It's not the size of a person. This is talking about inside the body. Okay, so you can't bank this on, well, they're skinny or they're a larger person. Body surface area. If you're marinating a chicken breast, the only thing I can come up with, okay, and you only have 30 minutes to marinate that chicken breast, the easiest way to get marinade through more of the chicken would be to cut it up into small pieces, because the small piece is going to have a lot of surface area for it to absorb. Okay, if you just took that big old chicken breast and plopped it down in marinade, not everything's going to get marinated. But if you cut it into small chunks, then that whole surface area of each one of those little pieces gets marinated. Does that make sense? Okay, that's basically what this is saying. The more surface area that medication is exposed to, the better it's going to absorb. Like with topical medication. It's over a surface area, so it absorbs better. Okay? Alright. I don't really go into lipid solubility that much. I will tell you that lipid-soluble medications absorb more readily, and that's all I'm going to say about that. Okay? We don't really use that a whole lot. If you look in your drug book, it will tell you if a medication's water-soluble or lipid-soluble. It's not something we use on a day-in, day-out basis. Alright, any questions about any of these? We're good? Y'all just want to get out of here? So y'all decided y'all just not going to say anything. Alright, distribution. This is getting the medication to its site of action, or getting it where it's supposed to go. And it's affected by a couple different things. It's affected by membrane permeability, the physical barrier that gets it in and out, okay? But the one that we are going to talk about is protein binding, so just get ready because this is a little deep. And I apologize, but I want y'all to understand it. Okay, let's see if I can. I tried to draw on this yesterday and it didn't work, so let's just do it here. Can everybody see if I draw real big right here? Okay. Here's your bloodstream. And in your bloodstream you have protein molecules. The biggest one being albumin. Okay? There's others, but that's the biggest one. Some of your drugs like to bind to these proteins, like magnets. Okay? So let's say that you have a drug that is a protein-bound drug. Each one of these little protein molecules only has a limited number of space that they can actually stick to. And there's not room for all of them. Okay? Bear with me? So they'll fill up the spaces on these proteins until they run out of spaces. But there's still medication kind of floating along in the bloodstream. The only part of that drug that can actually go to where it's supposed to is the part that's not connected to one of those protein molecules. Does that make sense? Okay. So, you're going to base your dosage of protein molecule or protein-bound medicine on that free agent. Any of that stuff that's bound, this stuff right here, is not going to cause an effect unless it gets bumped off of that protein molecule. Why would it get bumped off that protein molecule? Maybe another drug comes in and says, I'm more magnetic than you, so off you go. So if you've got two drugs that are both protein bound, you could have some issues with dosing there. The other thing is, albumin is directly related to nutritional status. Okay? So if you're nutritionally deprived, your albumin level drops. If you have less albumin, you have more of what? What's connected to the albumin? The more the drug. So if you've got a patient that is nutritionally compromised, they're going to require less of that particular drug because they don't have as many protein molecules for it to bind to. I told you it was deep, right? Okay? There's going to be more free-floating drug in the system that can cause an effect or cause a response. So as your albumin level drops, there's more circulating drug in your bloodstream.
So the more, what's the word for it? The more you're
Malnourished,
the more medicine you have to.
Right. So if you've got somebody that comes in and they're like, I can't, because coumadin is one of the drugs that does protein bind. So if they come in and they're like, I can't figure out why their coumadin level is so high. Well, check their albumin level. Because if their albumin's low, because they're not eating or whatever, then that's probably why their coumadin level's high, is because they don't have that protein that they may have had when they started the dosing. Now that they have less albumin, they have more drug in their system. Okay? So with your protein binding, the only part that can cause a response at the receptor, which is down here somewhere, okay, is the part that's not bound to a protein. Okay? And that's how you dose your medication. That's why with coumadin, we have to check levels. We don't want them to get too high or too low. So everybody with me on that? Do I need to go back over it again? One more time. Okay. In your body, and not all medications bind to proteins as readily, but some of them do. So you've got a set number of proteins in your bloodstream with set number of spots that they can bind to. So that drug goes and it finds its little spot. So the part of the drug that's not bound is what will go out to the receptor. I can't spell. Okay. Now, if something changes and there's decreased albumin, then you now have more drug that can go out to that receptor. Or if you have another drug that comes in and says, get off, I'm getting on, now you have more drug that goes to the receptor.
What would change to make the albumin go down?
Nutrition. Nutrition's the big thing. It also causes swelling because it handles some of the fluid shift, but it's nutrition that causes it. And it's not like if you had a virus, your albumin's going to completely tank out, but if you've been malnourished for a while, you'll see some drops in albumin. Okay? Good with that? Yes, no, maybe so?
Yes.
Okay.
When we're doing our calculation for medicine, are we going to have to?
No.
That won't matter.
No. That's the doctor's job. I'm just telling you it happens. And a lot of times, like if you had a patient come in, you may be the first one that sees that coumadin level's high, and you start going, what the heck? They're saying they're taking the same dosage, nothing's changed. And so you pull your labs and you see that your albumin's really low, then you're like, well, there you go. So then you just let the physician know. But yeah, we won't base our dosing on protein binding or anything. We'll just go by the physician's order. All right, the next step is metabolism. So after medication reaches its site of action, it becomes metabolized or broken down, and this is what we refer to as metabolism, okay? We typically think of metabolism as breaking it down or making it ineffective or less effective, but that's not always the case, but this is going to be changing it somehow, metabolism. And metabolism almost always occurs in the liver. Not always, because in nursing you'll find there's never an always, but your source of metabolism, by far the majority of the time, is the liver. Okay? So if you can't metabolize the drugs, you could have problems with drug accumulation because you're not breaking that drug down. So your patients that have liver disease or hepato is going to be liver. Anything that says hepato is liver. So if they have hepatomegaly or hepatitis, any disease process that can affect the liver can affect metabolism of drugs. So your liver failure patients, we have to be cautious with medications. We're good? Okay. All right. Alright, a couple things I do need to discuss about metabolism. We usually think of metabolism as breaking it down, but do y'all know how Tylenol with codeine works, what it converts into when it's metabolized? Morphine. Okay? Not the whole amount, but when codeine is metabolized, it actually turns into morphine. That's why it works so well. But it's not like 100% of that turns into morphine, only a small percentage. But that's the reason Tylenol with codeine works so well. Okay?
We need to know that.
Just FYI, you know. Okay, there's also something called first pass effect. First pass effect. And what this refers to is that it goes directly to the liver and it's metabolized to an extent that it's not going to cause any reaction in the body. So it's, even if you gave a medication that has a high first pass effect, this is we talked about oral, it takes the long scenic route and bioavailability and all that stuff. This is where that comes from, okay? If you've got something that's 50% bioavailable, 50% of that drug was lost somewhere. Okay? It was broken down. With the first pass effect, it's talking about the medication goes straight to the liver and it's broken down or metabolized to a point that it's not going to cause a reaction in the body. And the whole point that we give medications is to cause a response, right? Mm-hmm. Okay. So when we talk about bioavailability, this is why we have to look, or this is why there is a bioavailability problem with your oral meds.
Because you lose half of it.
Well, you can lose some percentage of it. It's not standard for every drug, okay? I just gave that example.
And it goes to the liver.
And it's broken down. Everybody with me on that?
But can you say that 50%, a drug that is 50% bioavailable has 50% of it it's broken down or it's metabolized and it's not going to reach its site. Okay? Now when you look at bioavailability, you can have any percentage of bioavailability. It just depends on the specific drug. And I'm not going to ask y'all to remember bioavailability percentages of each drug. I'm not going to do that. But if I gave you the example of you have a drug that's let's do something easier, I can't do math today, that's 50% bioavailable, then I could ask you, well, how much of that drug would you give if the physician wants a dose of 500 milligrams to reach that site? If it's 50% bioavailable, you're going to have to double that to get it, okay? Does that make sense? No? Okay. That other 500
is broken down and the body renders it ineffective. The exception to that rule, because you know in nursing there's always an exception, if you've got somebody with liver failure, they may not be breaking that drug down appropriately because their liver's not working. So you may, you would have a more standard to low dose of that medication. Okay? Okay. First pass effect. So with first pass effect, it means that it goes to the liver and it's broken down to the point that the body's not really getting any effect from that medication. And there's one specifically that I do want you to remember. Nitroglycerin, like the tablets that you put under your tongue. Has anybody ever had a nitroglycerin tablet that is swallowed? Okay, there's a reason why. Because it has a very high first pass effect. So when we teach patients about nitroglycerin tablets, we tell them to put them under their tongue. Because if they swallow it, the liver's going to break it down. But if they give it sublingually, it goes into the bloodstream and it doesn't have that first pass effect. So that's the reason that nitroglycerin is given sublingually. Or there are patches, but it's not swallowed as a pill. What's nitroglycerin used for? Okay, it's used for chest pain. It's the standard treatment for chest pain. But what it does is it dilates all your vessels. Guess what? It dilates your vessels too if you get that topical stuff on you. You don't have high blood pressure, so you'll be on the floor.
And it gives you very bad migraine.
It can give you very bad headaches, especially if your blood pressure was not up in the first place. Nitroglycerin, and y'all don't have to remember all the drugs right now, but it is for chest pain. It's a vasodilator. First pass effect is where the medication is given and it goes to the liver and is metabolized to such a percentage that the body's not getting any benefit from that drug. It completely breaks it down.
Now, what did you say we need to know about nitroglycerin?
Give it sublingual. Can't give it in a pill that you swallow. It won't work. That would be a good education question for your patient, if they need to give it sublingual. Somebody asked me earlier, what kind of questions would I throw at you? Okay? We haven't really covered nitroglycerin in depth, but let me give you an example of how it would work. I could say, you're doing discharge teaching for a patient that's being discharged on nitroglycerin. Which of the following shows the need for further education? And the correct answer would be that the patient states he'll swallow a pill every time he starts having chest pain. Okay? Because you can't swallow it. So that's kind of how the questions are. They're a little bit different. They're scenario-based. I'm not going to say which of the following drugs can you not give in an oral tablet that's swallowed. I'm going to give you a scenario, and you have to know some stuff to be able to pull that out. Still testing you on the same content, just a little harder question.
Wow.
Why? Why are you so mean? Because in nursing, it's not, it really, and we always get that question. But in nursing, it's not like, I'm not saying that any of the professions are not great professions, but it's not like with history where you just have to know that date. You have to be able to adapt your responses and your reactions to whatever the situation calls for. So by giving you situation-based questions, we're forcing you to learn how to critically think, which is what NCLEX is going to test you on. Sorry. It's okay. It's fine. All right, so metabolism, where is it done most often? Liver. What is first pass effect? Goes to the liver, it's metabolized, not doing us any good. Nitroglycerin was our example. We fixed that by giving it sublingually. Okay? Alright, the last process is excretion, which we said was what? Getting it out of the body. Which organ is primarily responsible for excretion? Kidneys. Kidneys are your main organ. However, they can also have some excretion from the lungs, the liver, the bowel, and your sweat glands, and your breast ducts for breastfeeding. Medication leaves the body through breast milk, okay? Alright, so the kidneys by far are the most important for excretion. Most of your drugs are excreted that way, so you do have to be careful with kidney failure patients. Okay? What do we refer kidney failure as? What's the other term for it? Renal failure. From now on, it will be renal failure. I will not call it kidney failure. It will be renal failure. Okay, you got to learn your body system. So a patient that has renal failure, are you going to give them more medicine or less? Less, because their body's going to hang on to it for longer. Okay. A lot of your general anesthetics are excreted through the lungs. What do we make our patients do after surgery that they hate us for? Turn, cough, deep breathe, and get up and move. So now we know why we make them do that. The longer they take shallow breaths, the longer that medication is going to stay in their body. So we want that general anesthetic to get out, open up their lungs, make sure they're not having any complications. Okay? So your general anesthetics are excreted. A lot of those are excreted through your lungs. With your breastfeeding moms, we did talk about that medication can go through the breast milk. So if you've got a mom that's breastfeeding, that is a special consideration. Most of your drug books for most of your drugs are going to say don't give the drug during pregnancy. Okay? They're just going to say that as a safety precaution. But there are very specialized drug books out there that can actually give you the percentage of how much of that drug would go into the breast milk. And then the physician would make the call as to whether or not he felt like that was a trade-off that they're willing to accept. Okay? So there are some very specialized drug books. You won't see them on the floor, but you will see them in labor and delivery and on OB. Okay. Alright, so that was pharmacokinetics, and that was what the body does to the drug, right? So now we're going to talk about what the drug does to the body. Alright, this is the process that actually determines the nature and the intensity of the response.
So this is what the drug actually does to the body, the response that we get. There's two different types of theories here. There's a drug receptor theory and there's a non-receptor theory. By far, the majority of your drugs will fall into this drug receptor theory. There's very few that I can think of that fall into a non-receptor. And I'm going to give you an example of the difference once we talk about them. Okay? This is the drug receptor theory. Drugs are not magic bullets. They're chemicals, and they can only cause reactions, which are responses, when they interact with other chemicals or receptors. This is known as the receptor drug theory, and by far the majority of the drugs work this way. And basically what happens is the medicine that we give, it's a chemical, goes to its receptor site, which is another chemical, and it can do one of two things. It can either turn that receptor on to make it work more, or it can turn that receptor off and block it to make it stop working or do the opposite. Okay? So your on switch is an agonist. It binds with the receptor and stimulates whatever the normal response of that receptor is. Your agonist or your on switches. So whatever that receptor does normally, that's what it's going to cause it to do. Okay? Your antagonist binds with that or goes to that receptor and it blocks it. So it's your off switch. Agonist is your on switch, antagonist is your off switches. So when you look at your drug book, you will see that some drugs are agonists and some drugs are antagonists. So now you know what that means. Okay? Let's say that that particular receptor's job was to vasoconstrict. What does that mean? Get smaller. Okay? And we have an antagonist that binds to that receptor. What's going to happen to the vessels? They're going to dilate because they're going to do the opposite of what that receptor said. Does that make sense? Okay. Alright, so let's say that we have a receptor, and that receptor's job is to cause vasoconstriction. That's what it does. But we have an antagonist that blocks that. What's going to happen is you're going to have vasodilation. Okay? Because it's going to block that receptor from doing its normal job, which will cause the opposite reaction. Everybody good with that? So if we had that same receptor, but we had an agonist to that receptor, what's going to happen? It's going to clamp down. Good?
So it not only turns it off, but it makes the...
By turning it off, that one's not doing its job, so you'll actually get the opposite effect.
Because
the normal response is not there. Yeah.
Use that in a pill form or something.
I can do that. Okay. ACE inhibitors block a chemical, and they're an antagonist, and they cause vasodilation and then drop the blood pressure. That's how they work. And
So
we'll get
if we had, like if somebody was taking a pill and we had to look something up, we would look for something that would turn it on.
Depends on what you may be looking for either or. Depends on what you're trying to get the body to do. Like if you had a patient whose blood pressure was really low and you were trying to get them to clamp down, then you're going to look for an agonist that's going to cause vasoconstriction. And a lot of times, sometimes you'll see this in the drug book, but a lot of times your classification is going to tell you whether or not it's an agonist or an antagonist. I mean, you know if it's dropping the blood pressure, it's definitely not causing vasoconstriction, because that's going to make the blood pressure go up. So I don't want y'all to get overwhelmed by the terminology. Just if you know what it is, you know if it's on or off. I'm not going to say, well, is, Fuji bomb, is it an antagonist or an agonist? I'm not going to ask you that. I'm just going to say, you've got a drug that's is an antagonist that, the receptor normally causes vasoconstriction. What's the anticipated response? And it would vasodilate, or something like that. Agonist is your on switch, antagonist is your off switch. Okay. Let's see. All right, so we talked about your receptor theory. We've got a couple more terms that we're going to talk about, and then I'll compare the two different types for you. Potency. What do you think of when you hear the term potency? How strong it is, okay? So basically what potency says, if you gave two drugs at the exact same dosage, the one that elicits more of a response is more potent. It's stronger. So if I gave 10 milligrams of morphine as compared to 10 milligrams of Tylenol, which one's more potent? Morphine by far. Okay? And just while we're talking about potency, and we will cover it when we cover your rest, sleep, and comfort drugs and talk about a lot of the narcotics, we are given Dilaudid a lot in the hospital right now. It's about, just to give you a reference, it's about 7 times more potent than morphine. Dilaudid. Okay? Very good drug for some patients, but the only time in my nursing career I've ever given Narcan was after I pushed Dilaudid. So, it will definitely send you into outer space. So.
What did you mean, Dr.
Narcan's the antidote for it, because the patient went into respiratory depression. Just be careful. Dilaudid is a good drug, but it also has its downfalls. So, all right. So potency. What does efficacy mean? How effective it is. So basically, for this terminology, efficacy means as you increase the dose of that drug, you're going to expect a more pronounced effect. So you would expect that the patient gets more pain relief from 5 milligrams of morphine than they would from 2 milligrams of morphine. As you increase that dose, you would expect that you get a bigger response. Okay. So that's potency and efficacy. So if I go with that, how strong it is. It's how it. Yes, it is how effective it is, but it basically says that as you increase that dosage, you're going to get a more pronounced effect. You're going to get a bigger bang for your buck, so to speak. Okay. All right, non-receptor drug actions. These are drugs that work simply by either a physical or chemical reaction. Antacids work this way. So this is going to be my example, and I'll compare it. Antacids, when you take Tums, it doesn't go into the bloodstream and find a receptor and do anything. It goes into your stomach. Whatever acid happens to be there, it neutralizes. Okay? That's a non-receptor theory. It just simply neutralizes what acid is in the stomach. It doesn't go anywhere else. That's what happens. Just a simple chemical reaction. Okay? To give you an example of how a receptor theory would work for the same condition, if you have a patient that has a lot of acid, they typically put them, give me a drug that we use for like an antacid type drug, pill. Prilosec, Prevacid, Protonix, Nexium, all of those are antacid medications. What they do is they actually go to the bloodstream and they find that receptor that says, I'm supposed to produce acid. And it's an antagonist, it blocks it, so they stop producing as much acid. So that's how that one will work. Even though you're using them to treat basically the same condition, they work completely different. Oh, a light bulb moment, right? There you go. Anybody need me to repeat that?
Yeah.
I was real proud of myself when I thought of it.
The last part, it was the first part.
Okay, the antacid part? Yeah. Okay. With the antacid, when you take Tums, you pop it, you chew it, it goes down your esophagus into your stomach. Whatever acid's there, it simply neutralizes what acid is in your stomach. It doesn't go into the bloodstream and say, let me find a receptor to bind to. It just says, hey, I'm here, this is my job, what I'm going to do. Okay? Neutralizes what's there. But with your Pepsid or your Nexium, it's why it takes longer to work, but it goes through the bloodstream, finds a receptor, the receptor that's responsible for producing acid, and it blocks it. It says stop producing acid. So you produce less acid, therefore you have less acid in your stomach. But they work completely different. I know, I'm so proud.
So what category would the Prilosec be?
It's still going to be probably an antacid, but it's not going to be like a Tums. Like when I'm saying antacids on here, I'm talking about like Tums or Rolaids.
So would it be considered it would be considered a receptor drug?
Yes. Tums is a non-receptor drug. Pepsid is a receptor drug. Okay. A few more little terms we need to go over. Loading dose. Loading dose. A lot of times when patients come in, we will give them a loading dose, which is a large initial dose of the medication. Like, for instance, if somebody comes in with a blood clot, okay? We want to get their blood thin really quick because we don't want any further problems. So we'll give them a whopping dose of heparin to get their blood thin, and then we'll supplement that with either a drip or some type of other medication. So a loading dose is going to be a large initial dose to help get it in that therapeutic range, and then they'll maintain it with some other type of medication or a different dosage of the same medication. So it's that initial large loading dose. Sometimes you'll see that done with antibiotics. If we're wanting to get them into that therapeutic range really quick, we'll give them a massive dose, and then we'll give them a less dose to kind of keep it there. Is that okay with that? Placebo. What is a placebo? It's a fake medicine. In the older days, they used to give placebos in the hospital. To your patients that came in that were drug seeking or they thought were drug seeking, they would say, okay, here's your pain medicine. Shh, but it was saline. And they would see if the patient actually got benefit from that or not, because if they did, then it was psychological in their head and they weren't actually hurting in the first place. We don't do that anymore, not in the hospital, okay? But there is a reason that we use placebos. Can you think of why we use them? In your drug trials. When you do drug trials, the patient signs an informed consent, which you'll learn a lot more about, but it tells them that they may either receive the active ingredient or a placebo, and they're not going to know which one they're receiving. But it helps us identify if that drug is really beneficial or if the patient just thought it was beneficial. So they had the psychological effect on it. Okay, so we do use placebos in our drug testing and that kind of thing. Okay? Alright, serum half-life, we're just going to mention it. I put a lot of stuff on here. I'm not really, we're just going to mention it. Here we go. Alright, time it takes to lower the serum level of a drug by half. That's all I'm going to say about it. Forget all this stuff. Just know that if you've got a drug that's got a short half-life, then that drug's not going to stay in the system very long. If it's got a long half-life, it's going to stay in the system longer. That's basically what that means. So we're going to move on. Okay, I guess that's it.
So tomorrow we'll start on Z.
Do what now?
Tomorrow we'll start on
No, tomorrow y'all will have, yes, B for 102.
Okay.
Yes.
So what do I have?
You have me, but only because I'm helping Miss Brown.
Okay, so we don't actually have your class.
You don't have my class tomorrow.
Okay.
Monday you want,
Hey, hang on everybody, hang on. Do what now?
Monday you want a general survey done?
No. What we'll do Monday is we will cover the notes on general survey, health history, and then in the lab we will start vital signs, the lecture part of that. What's due on Monday is that Module 3 on your online skills. So if you do that by Monday, then you can get bonus points on your first health assessment test. If by some chance you don't have access to that course by Monday because of the bookstore issue, I will extend that deadline.
And that's on the basic nursing thing.
Yes, that's the basic nursing thing that you register for 102. Oh, thank you. Thank you. Yeah, that's fine. Thank you. If you have your learning surveys, I'll take that. If not, that's due next Wednesday. Yes. Because the next module that we'll do is math, and there's really not a reading attached to that. So 1 through 6 will get you caught up.
me Narcan. I just had thyroid surgery.
Mm-hmm.
I got in recovery and I wasn't awake good, and they go, "Are you hurting?" Of course, I had pressure and I'd just been extubated. So she gave me some more. I don't know if she didn't know how much morphine.
Sometimes people are just really sensitive to it. Was it morphine or was it Dilaudid?
No, it was morphine.
Was it?
It was morphine. I got in ICU because I bled out. Plus, I worked in ICU too, and they wanted me, take care of me.
That's good. That's
Yeah.
be an ICU.
But they did call a second surgeon in, but my blood pressure bottomed out.
Yeah.
And they came in there and gave me the Narcan. And, yeah.
Of course, I mean, the only flip side of that is all the pain you were in has just now been brought all back. But, but a lot of times they'll give you morphine right behind it.
No, what they did is they gave me just a little bit of Narcan, just enough to
kind of reverse all of it.
Yeah. Yeah.
Do you want the surveys in a folder or just?
Stupid question.
No question is stupid.
Okay, you said metabolizes morphine.
Yes.
I'm allergic to codeine, so
You may be okay with morphine because the way it's made, so you may be okay with morphine.
Okay.
I mean, we always, if you are allergic to codeine, we watch you closer, but it doesn't necessarily mean that you can't have morphine. Because it may have been the actual codeine itself that you're allergic to, not the morphine.
Yeah. Okay.
Mm-hmm.
This tactical morning thing that we're supposed to do.